as we are in the, as Beth says, the end stage of the third wave, and just to use a little bit of additional information, the flu epidemic of 1918 to 1920 killed 50 million people.
Wow.
Just to get that into perspective.
Mm.
And 50 million people was a very large proportion of the population of the world at that time. So there were no vaccines in those days. So it's vaccines that are riding to our rescue, but back in those days, you just had to sit it out, and it was a brutal virus. But it's a useful lesson to know that we had no vaccines, and yet the mortality caused by that virus gradually faded out over about 2 years, quite naturally, because that's what these viruses tend to do. Right, so getting back to COVID. Okay, vaccines. Okay, so the first thing I thought I would say, if I'm talking about vaccinations, I should probably bring you up to date with the situation of developing a vaccine for aspergillosis. Talked a lot about viruses this year, but there isn't actually a very active research effort going into developing vaccines that will work against Aspergillus for reasons of trying to improve the immunity that vulnerable people will have who are vulnerable to Aspergillosis. So from all the stuff we've learned about Aspergillosis and who's vulnerable and why you get Aspergillosis, we will be able to work out the fraction of the population who are vulnerable and vaccinate them. And this is probably the series of events that we're all actually reasonably used to. How to develop a vaccine, select your target. See, the first two stages, identification of target, select a target, were done in one weekend for COVID. Designing a vaccine strategy, well, they've been designing the vaccine that's currently in a lot of people's arms for over 10 years. So that took some more time, but that took a lot of research effort. And that's obviously reached a successful conclusion. Delivery system comes into that. Target model route for the infectious agent. Well, that's going to be we don't with COVID. That's another virus, so that could easily be done with for Aspergillosis. It could the vehicle could be another virus, just like COVID. But the only vaccines I'm aware of are just using the more traditional approach of breaking up. I think it's another fungus. It's actually yeast is the only one I've heard about, and injecting that and seeing if that confers immunity. And in mice, it actually does, just a particular species of yeast. But sadly, there have been a number of candidates that have got as far as step 7. They've gone into trials, and they haven't got out of trials. They've failed trials. So sadly, at the moment, although there is an ongoing research effort, there are no successfully tested vaccines for Aspergillosis as yet, which is quite something when you think they've been. The first paper I read about this was 10 years ago, so 11 years ago, and considering it's taken 11 months to generate the vaccine against COVID, that just tells you how much work has been done in the last year. So it's not yet been successful, but I know those efforts are continuing. So vaccines against COVID, the state of the game, as we all know, we have current access to 3 vaccines, I think it is now, and there's at least another one coming in the summer, which we all heard about in the news this week. We also, about more than 10 million of us have been vaccinated already, and a large number of the highly vulnerable CPA Aspergillosis patients I've noticed in the Facebook groups are all getting vaccinated in the last week. So obviously this is working really well. We're getting sort of 500,000 a day on average being vaccinated, which is brilliant. Another 15 million to be vaccinated are going to be vaccinated by the end of February. I think that was the target. And when they're all done, there are about 65 million people in the country. So it doesn't 25 million is less than half, but that 25 million account for 99% of the risk groups that are ending up in hospitals. So by the end of February, 99% of the most vulnerable people, the people who are ending up, who are using up hospital beds, will have received their first vaccination, which would be amazing. Also, everybody working in an NHS hospital is being vaccinated, so that the workforce are protected. So that works on both ends of expanding hospital capacity. So all that's really good news. The vaccine takes 3 to 4 weeks to actually produce significant immunity, but end of March, you have to wait till end of March for that immunity to increase. And we're probably looking at 89%, 90% of the most vulnerable groups will have significant immunity, probably around 50%, 50, 60%. By their measure of immunity, which is a measure of symptoms. But both the Pfizer and the Oxford vaccine have said that nobody ended up in hospital. So 100% efficacy to keeping people out of hospital. And you can imagine I think this morning it's about 19,000 a day are being identified as cases, and it's several thousand are ending up in hospital. That will fall to virtually zero, all things considered. So theoretically, we're about 8 weeks away from emptying the NHS out of new cases of COVID-19. So the end is very much getting closer. In my opinion, this is theoretical, working on the figures of the clinical trials. Things could go a little bit wrong, and I'll talk about those in a minute, but my opinion is we really are looking at the end of this outbreak in the UK. This is the graph that Beth just showed us. I just put it up. This is daily cases, and just for illustration purposes, the first vaccinations happened right at the beginning of December, so right in the trough here. You remember with the number of cases were building up, and then we went into various regional lockdowns, and that seemed to force the numbers down. But then this new variant arose, and now known as the UK variant, I think, and numbers quickly started climbing. But we were vaccinating all this time, maybe not at the levels that we are doing now, but we were starting to vaccinate. And there's a little notch in the slope there, and that's when lockdown happened. So I think that's probably Christmas, Boxing Day, that type of time. The cases, as we know, carry on, and then steep drop. So if you can compare that to how fast this, that long, slow drop, this one was dropping quite fast, but then a new variant came in. This is a very, very sharp drop. Could be, it's obviously partly to do with the lockdown, but as we go along, it'll be more to do with vaccination as well. And essentially, this should drop. And if the vaccinations work as we think they will work, once that has dropped, then we can ease up and it will go up again because people are as much higher levels of immunity. So fingers crossed. That's also giving us really good news. It's still regional. If you remember, the north, sort of October, November time, north had a lot of cases. And then by Christmas, the south was getting a lot of cases because of the new variant. And that spread up the country, up the country and more or less taken over the country. But the number of cases in each area are depicted on this map. Sort of the darker colours are where there are more cases, and you can see that it is actually already, this was done for the 4th of February, so yesterday, a number of cases are dropping. There's still a few places with very high levels. Wales is almost completely recovering. Northwest is doing pretty well, and the Midlands are doing pretty well, and the South is doing really well. So showing some serious signs to be confident about suppressing this outbreak. Deaths, as Beth said, right at the end, we can start to see we've reached the peak of deaths, which is what the government mentioned this week, and it's starting to fall. And I'm probably biased, but I can see a much sharper fall here than there was here. I think that's going to fall quite sharply, the number of deaths, which will reflect the vaccines. So again, good signs that we're probably 2 months away from, at the most, from starting to see the end of this lockdown. Everyone's worried about the variants, so I just thought I'd do a little summary on that. Variants are the original virus. These viruses change all the time. Their DNA sequence mutates and changes as they pass through different people and different populations. And ones that are better at spreading will be the ones that take over and start to dominate. And that's what we saw with the UK variant. We saw on the cases how fast that particular variant took off. It's much more infectious, much better at spreading, increased transmission, nearly twice as much. I put 70% there, but I read something earlier on that said it was twice as good at transmitting itself to people. For the first time I read that it actually, we think it's about 30% more deadly. It's got a higher mortality rate, that virus, and that would account for why the hospitals are fuller than they were last summer. Tends to affect younger people. But we've also had 2 more notable variants. There are actually thousands of variants, but these are the ones that seem to be becoming more popular, more common, and the ones that we're a little bit more worried about. The South African variant we're concerned about because it seems to be able to avoid existing COVID antibodies to some extent, but it's not. It's by no means going to take over and be a 4th wave. It's not that infectious. There was no particular change in how it transmits itself, and there's no particular change in the number of people it manages to kill. Existing vaccines are slightly less effective against it, but we don't think it's very much. So we're still going to have a very resistant population if the South African variant starts to spread in our population. Similarly, the Brazilian variant, I'm not sure if that's been noted in this country yet, but it's out there, and there's lots of other variants around the world, but this one's out there. There are some signs that it can evade parts of our immune system and then cause reinfection. There's a few cases of people who've already had COVID and they get reinfected with this variant. But again, the current vaccines seem to be effective, and the new vaccines coming out will be tweaked slightly so that they are even more effective against these variants. The important thing is that we're tracking these things. And here in the UK, we're probably the best in the world, and we have the biggest databases and the biggest research efforts to track these variants, keep on top of them, anticipate their arrival, and take the appropriate action. We've got the vaccines that we can change to compete with anything particularly nasty that comes in, probably much the same way as we treat 5 or 6 different variants of flu every year. We will probably be treating 3 or 4 different variants of COVID on maybe a yearly basis, maybe a 2-yearly basis. We don't know, but at the moment we're mostly concerned about getting out of this lockdown and getting back to normal. I would say more than anywhere in the world, with the possible exception of Israel, we're ahead of the game on this. We were leading the world on this. That link at the bottom is where you'll get more detailed information on all those variants. So they are of concern, but none of them are going to wipe us all out or anything like that. They're slightly different, slightly more evasive, and we just need to be aware of them and track them and make what adjustments are necessary. The variants will continue to arise once we have vaccines in place because they're effectively, the vaccines are putting selective pressure on the viruses that are in the wild. And the variants of the virus that are able to avoid our immune system the best after we've been immunized will probably be the ones that persist and remain. But the fact is, even if we're only 50% and vaccinated people are more than 90% resistant, even if we're only 50% resistant to these viruses or the new viruses, the R0 that we've all heard a lot about will be well below naught, and these viruses will die out in our country and around the world once everyone's been immunized. We know there's been a lot of debate about the fact that we're getting one vaccination and then we're leaving it 12 weeks before we get the second vaccination. And work that's been done seems to support that this week. With one vaccination, we're getting up to sort of 80–90% immunity after a couple of months. The 2-dose will give us greater than 90%, so it's a little bit higher, but not massively higher. And right at this moment in time, we need that 80–90% immunity for all the at-risk groups as quickly as possible to eradicate this virus. So I would support the one vaccination strategy for the moment. The other thing that we'll all eventually get the 2 doses, and the other thing the second dose gives you is immunity for a longer period of time. So the other aspect that's been talked about repeatedly is that the vaccines we're talking about are actually designed to stop people ending up in hospital. So they're designed to reduce symptoms. They're not designed to stop you getting infected. They might stop you getting infected, and that's not been tested in any great detail until now. One important point is, even they were designed to stop people ending up in hospital, and you see figures. The Oxford vaccine, I think, got figures of about 75%. The Pfizer vaccine got 87%, something like that. Both of them are 100% effective at reducing symptoms and stopping you going to hospital. So again, the point is made that hospitals will be, the whole health service will be fine in about 8 weeks' time. That is my prediction. There might still be a small proportion of people who can be infected, but that will die out as R0 falls to a long way below 1. But what about transmission? It's one thing talking about we're all safe because none of us are ending up in hospital, but that means the virus might still be able to be transmitted, be infectious. It just can't hurt us particularly. We need to know about transmissions, especially if we're going to do things like travel to countries where the levels of vaccination aren't very high. And right back at the start, yes, back in July last year, you might remember, I think I mentioned when they were designing the vaccine, and I said there wasn't the remotest chance that we would have a working vaccine by the end of the year. So I was quite a long way wrong with that prediction. They tested that vaccine. One of the first tests that was done was on macaque monkeys, and it found that while the monkeys were protected from serious illness, just like us, it did not prevent them becoming infected. vaccinated monkeys were as likely to become infected as the unvaccinated ones, although they did have fewer viral particles in their lungs. So the question remains, is the vaccine able to restrict transmission? We hope it will be, but it's by no means the primary purpose of these vaccines. However, just this week, 1st of February, was the first study that's looked at transmission, and researchers have found that the vaccines cut the number of cases with detectable virus, and you have to have detectable virus to transmit the virus, obviously, is cut by 2/3 after one dose. So that's a huge reduction in transmissibility. That will be a huge reduction in the R0 number that we're all used to seeing. And the quote there is that these vaccines, this was the Oxford vaccine, but I'm sure the Pfizer vaccine was similar. This has the potential for a substantial reduction in transmission. So again, it's all good news. These vaccines are showing us the way out, and indeed experts and scientists and doctors are providing the solution.